Here they come.
Welcome, everybody. Just going to give us a few more moments while folks join from the waiting room. Okay. I've started to wonder, Megan, if our little preamble at the beginning, everyone knows we're going to do that, so they just sign in 5 minutes late.
That's possible. I know we have to shake it up a little bit.
I think you're right. I think you're right. Okay, well, I want to make sure that we don't lose any of the precious time here. So I'm going to get us started. Welcome to everyone. My name is Margie Beaudry. On behalf of Trust for America's Health, I'm very pleased to welcome you to today's Huddle call to discuss challenges and solutions for ensuring access to COVID-19 vaccines for older adults and people with disabilities who cannot leave their homes. I'll ask you to please mute your lines unless you're speaking. This session is being recorded so that we can capture all the ideas and experiences shared. And this call series is part of an initiative to identify and foster adoption of innovative and promising practices on this topic. This work is made possible through the generous support of the John A. Hartford Foundation, which works tirelessly to improve care for older adults, and the Cambia Foundation, which is dedicated to improving the way people experience health care. Access to the COVID-19 vaccines for older adults is being prioritized across the country due to the vulnerability to more serious illness from the virus among this population. However, for the estimated 15 million older adults and individuals with disabilities who do not leave their homes, access is challenging or impossible. These challenges are not well understood, but government agencies are beginning to attend to them, and the vaccine supply is increasing. But state and local health departments across the country, working in partnership with the Aging Network, hospital systems, and other community partners, are turning their attention to this population, and a variety of innovative practical solutions are emerging. This issue is also generating attention with the media and federal agencies, including the VA, CDC, and ACL, and other stakeholders. But there are still a lot of complexities, and there's no single strategy for ensuring the vaccines get to those who are homebound. We're all learning together at this critical moment in time, and these Huddle calls are designed to share just-in-time or just learned information as broadly as possible. In studying this topic, we are seeing some themes emerge. Over the course of this call series, we expect to touch on each of these themes from various perspectives. This graphic depicts the themes as separate. However, in practice, they are interwoven and interdependent. A change in resources or implementation strategies in one area has a ripple effect throughout the system. Today, we will hear from Tom Lally, who will speak about a statewide program to vaccinate those who are homebound in Colorado. And after his remarks, we will open it up for questions and discussion. And I will turn it over to you, Tom.
Thanks, Margie. And I want to thank everybody at Trust for America's Health and Ripple Effect for the opportunity. So who is Bloom Healthcare? We're a Colorado-based company. We are employee-owned. I think that's important. We don't have endless resources, and we're very mission-driven. We deliver very comprehensive home-based primary care and palliative care and on-demand for about 6,000 frail and mobility challenged patients each year across the Front Range of Colorado. These include some specialty visits, but a lot of palliative and primary as well. And we have fee-for-service and value-based contracting, and today we take care of those patients with about 50 employed providers. We empanel them and support them with clinical support and administrative leadership. Bloom is not a home health agency. We are not concierge medicine. We serve Medicare and Medicaid patients who need our services. They don't want our services. And we're not a typical office-based practice. We have a ton of logistics because we do this every day, and we've been doing it for about 20 years in our footprint. And we're not a vaccine-only provider. We got into this because it was the most important way for us to be able to cure the problem for our patients and for our community. Next slide, please. A little bit of our experience to date, like who we are before we got here. We invested very early in kind of being ready for the vaccination effort. So we have plenty of super freezers and pharmacists and protocols to be able to make sure that we did it right. But today we've done about 10,000 vaccines. And you can see we've done this in kind of two different varieties. We have our parking lot clinic, which really wasn't very effective for our patient population. Some of the most mobility able patients actually got to the parking lot, and we ran out of patients after not too long, and we had to go on site. Our patients live in both congregate settings and in private homes, and it was much easier for us to go to congregate settings, independent living, senior housing, folks that were actually forgotten about in the federal programs because they weren't licensed congregate settings. We did mass vaccinations, and today we've done about 10,000, primarily in that 65 and older population. Next slide. We were asked, because of this success from the state of Colorado, to what it might look like for Bloom to vaccinate all of the homebound patients in the state of Colorado. And I paused and realized this was a huge ask. They didn't really have a whole lot of detail about what it meant. And so we went home and really thought about it. And we said, well, we think we can offer a pretty viable solution covering about 85% of the state's population, who live in about 12 counties. They're not all contiguous, but we were able to say, hey, I think we can really do some good work there. There's enough density. We can complete it by the end of 21. And we made some assumptions that about 1% of the population will need vaccination at this point. Some of them have already gotten this through congregate settings and elsewhere. And maybe 50% will maybe refuse this. So we estimated approximately 50,000 doses, 25,000 patients. And this slide's a little bit old with Johnson & Johnson. It's just to 25,000 doses. And we felt that home health agencies would be an important part of this for us to scale quick enough and for us to use some subcontracting and some licensure and some really well-trained people to help us get vaccines in arm quicker. And you can see this is how we broke down the population by county. Next slide. We had core competencies, and what blue is in blue is really Bloom Healthcare's core competency. This is, we were a vaccine provider. We have logistics and intake. We made sure that we were going to continue to do those functions with our, any proposal, because that really was where we gave the management and quality control level where we could make sure that there was consistency. On the right-hand side, and primarily in green, these are really either subcontracted or new Bloom workforces that we would have to hire. So these are RNs that we're going to have in Colorado. We could use EMTs as well, but I used RNs for the example. Background tested, do some training, and then we're going to enable them with the tools and resources to go out and do the vaccinations. And we are estimating, depending on density, up to 10 patients a day could be vaccinated, but we're going to give them all the tools like EMRs and vaccine consent. This will be a pre-done logistics schedule and any of the requirements for monitoring and any type of problems that might happen. And then you can see at the end of the day, they're going to return this back to us so that we can really have a workforce that can work one day, but hopefully once they're trained, they can work several days for us. Next slide. I won't spend much time on this slide. I just want to give people a little bit of an idea of what some of the extra components when you're going out into the field, and the number of available units that you can keep temperature controlled refrigeration and plug into a cigarette lighter that are available. Very few. It's the time, it's hard to find those. And so you do have to use other resources, and we use a kind of combination of as many of the electronic ones as possible. And otherwise we use, really digital data loggers, continuous temperature monitoring, and then bubble wrap. And temperature stability is often done with conditioned water bottles, and we're monitoring that, consistently. And then we label these, make sure that when we're going out, we're trying to make sure that it's as efficient as possible. So a lot of the scheduling considerations upstream can make this much more efficient once we get into the field. Next slide. So this is probably one of the most important parts. We really felt that we needed to control this. Nobody else could really schedule for us. We needed to maybe get a pre-screened list or a group of individuals who may be interested in the vaccine. But then for our logistics purposes, we really needed to group these into territories and then into individual routes so that we could make efficient use of the provider's time and get as many vaccines done in an arm as possible. Also balancing that with the number of vaccines in a vial. So you're always trying to, go to these, round numbers. Next slide. It's a lot of workforce to do this. And really, this is something where today we've done our 10,000 vaccinations primarily with our own existing workforce. This is something where people worked on nights, weekends, extra. But to do this at a statewide level for non-Bloom patients, we really have to have quite a few people, and it starts with a really well-supported manager. Patient relations is important, but quite a few schedulers, routers, receptionists, data entry, couriers are all really important, and they scale with your capacity. And then we feel that really to be able to do this, there's a kind of combination of workforces where we'd also have subcontracted workforces and be able to pay fair market value in a very contractually clear way to a home health agency or to an individual that wants to work as part of the program. Next slide. There's significant upfront costs, and we broke it up into kind of two different categories. One would be the upfront cost to just stand up a brand new business, like instantaneously, because nobody has like this existing capacity day one. And then there's also a cost per dose, which really is much lower because of that upfront cost. If you blended it in, it would be a little bit higher. But you can see a significant portion of that is really external contracted medical expenses and program administration, operating expenses, and then the unknown and any profit. Next slide, please. We certainly thought about some potential headwinds. Lower than expected participation, those last mile challenges in some of the more difficult to reach or low population areas, just scheduling inefficiencies and staffing shortfalls. But we really felt that there was also kind of a balance of potential tailwinds. We thought there was going to be potentially higher than expected participation in some areas, and we had really good relationships with home health agencies. And we certainly know that there's some homebound patients who are going to be accessing vaccines through alternative means. We've seen this in many of the footprint that we already service, but there's still a lot of unmet folks at home. And we also feel that, just making sure that we go out there and see these patients, spend the right amount of time, not too much time, and being very efficient was going to be another good way for us to just kind of get to the right numbers at the right time. So I know I covered a ton of information. I also left out a ton of information, but I think this is my final slide. So I wanted to make sure that there was certainly enough time for any questions.
So thank you so much, Tom. And as you all can see, we have some question prompts on the screen. I want you to feel welcome to pop a question into the chat or just raise your hand and we'll get to you. But I have a question just to start off. Sure. Because I know that the state didn't just call you out of the blue and ask you to do this. Can you talk a little bit about what transpired in your efforts before the state asked you to do this, in such a broad way? Because I think that journey will be very instructive to folks whose states might not be knocking on their doors either.
Sure, it's one of those slides I didn't know, but it's a great question. And we started very early preparing. We were kind of first on the pharmacy list. We were the first vaccine provider to say, hey, we want to be a phase 1. We had our freezers and protocols. And then it still took a tremendous amount of advocacy. We called all throughout December saying, hey, you didn't forget about us yet. We serviced 6,000 of the most frail elderly patients in congregate settings, and we need to get out there. And it wasn't until the very end of December that I think we received 50 doses. And they said, call us back next week. And we called them back the next day saying, we're done, we're ready to get more doses. And we got 100 doses the next week. And again, we were done in a day. And they were kind of like, wow, these guys are moving pretty fast. And it was that relationship that started really early. And it started actually at some of the county levels. We were going to county health departments, to the state, pretty much to anybody, because we didn't have a clear pathway, and I don't think they had developed clear protocols yet. So we were really kind of loud in a very nice way of saying, hey, we're here, but we're here to help. And we have very sick patients. And it was as we started proving that we were doing this and going out in the field and bringing it into assisted livings, that were maybe raising their hand to the CDPHE or public health department and saying, hey, we didn't get on the federal program when we need help. They connected in with Bloom. Bloom went out and solved the problem. And we started getting really good feedback, and it got us into a spot where most weeks they were kind of asking us, hey, what do you need for your vaccine efforts this week? So by the end of January, because we were doing some of the most difficult and underserved populations, we were often given like reserved supply of vaccine that was really preference for these populations, and they knew we were going to do the logistics to get it out into arms. So it was a relationship that started not very many months ago, but it's blossomed into the spot where they really trust us to be doing a lot of this work. And it was after about a month and a half of that they really asked us to do the entire state.
Thank you. Megan's got her hand up.
I thought I'd raise my hand this time instead of just blurting out. So a couple of questions, Tom. Thank you so much for this great work and for obviously a lot of thought that's put into the planning and operationalizing your strategies. So my first question is there flexibility to also vaccinate caregivers when you go into the homes? And then the second one is the state of Colorado paying, or who's reimbursing for the whole, the entirety of the cost that you're incurring?
So the first question for caregivers, yes, we absolutely assumed that we would be doing caregivers and that it would be caught at that kind of scheduling level. So if we were going to do 10 patients that day and we were going to do 10 caregivers, we'd bring extra doses accordingly, but still have the same number of stops. So we thought it was actually a pretty efficient way to do that. And I didn't get into the breakdown, but we had a less cost per dose on those extras because it's really only one stop with some extra doses. Same with the husband and wife. For the payment, really, we were going to be working with the state of Colorado to access, I think, a couple of different funding sources. One was state funding and also FEMA. And it's the reason this is not totally complete at this point is because of that process that has to go through for the procurement and to really finalize us getting out into the field to do this project. So we are in the final stages, hopefully, of negotiation with the state of Colorado, but it will be accessing FEMA dollars and state dollars. We will also be billing for any available existing payers. So if somebody has Medicare, Medicaid, commercial insurance, we will be billing that to substitute, and then that would just decrease the cost to any existing, state or FEMA responsibility.
And that's a really complicated process, and I imagine not every home care, home health agency is going to be able to handle those kind of logistics. I guess I also have another question about whether Bloom is Bloom in other states, and if you're in other states, is this happening in other states?
So we are only in Colorado, and I am aware of other states that are having vaccination efforts. I know New Jersey and the VNA have been doing some really cool work, but I don't know of a lot of other states that are using home-based primary care as a method.
Thank you.
Wonderful. So I'd love to hear if others have questions. I don't see any questions in the chat or see any hands up. So feel free to continue to offer your questions. But in the meantime, Tom, let me ask you, what elements of what the state health department has done could be a model for work in other states, for work elsewhere across the country?
I think really from our standpoint, one of the most helpful things for us was just to have an open dialogue with the public health department and know who to call. And they knew who to call likewise. If they had problems, we were there to answer the phone and try to help them. We weren't just calling them saying, hey, we need vaccine. Hey, you need to come do this. Hey, you need to do that. We were calling them and saying, hey, how can we help? And the first couple of times people don't really believe you, and then you solve it a couple of times and that trust builds. So that was the most important thing, is for us to really be advocates and to be trying to help, and not just to be saying, hey, we need more.
What would you potentially do differently if you were to start this over again, knowing now what you know?
Um,
Or
we
maybe another way to put it is, what advice would you give those who might not have started this yet and might be thinking about it?
That's yeah, I think that's the more pertinent, Margie. And I think it's really to start at your county and any counties that you service. If you, regardless of the size of your agency, we've now worked with 15 different counties inside of Colorado. They've all been different, but we've been able to develop a relationship. Somebody will eventually call you back. It's not the first time you call and leave a message with the wrong person, but if you're an advocate, you will be able to connect. They are engaged. They're trying to figure out solutions. If you're coming up and saying, hey, I'm willing to be a partner in this, let's come up with some solutions. Do you have any considerations for how to get homebound patients done in this county? They may have a plan. They may be using EMS. They may be willing to, completely collaborate with you and to come up with a plan. And we've seen that happen at the state level now, and we've actually seen it happen at some county levels. So I really think that starting that conversation early with the public health, they really control the vaccine, and they're working hard to try to come up with public-private partnerships that make sense. They just don't always know who to call. So get yourselves out there and advocate.
We have a question from Karen Chapman. Karen, why don't you unmute and introduce yourself and ask your question?
Hi, Tom. This is
Hi.
Karen Chapman. I'm a local health officer in the state of Florida in a place called Okaloosa County, which is out in the Panhandle Central Time Zone. How did you, I have actually two questions. I was typing a second one when Margie asked me to speak. How did you manage the observation periods? Was it the same group of staff who vaccinated, or was there a separate group of people that came behind for those observation periods?
We used the same person, and then we scheduled accordingly. So we tried to find out if anybody was going to have a history of anaphylaxis. So if we know we're looking at a 15 or a 30-minute observation, if we have two people in the home, we're going to vaccinate them both and watch them at the same time. And so, but we really wanted to make sure that that's really part of that licensure level where we felt like there was probably folks that were authorized to give vaccines, but really weren't qualified to do the observation period. So nurse practitioners, RNs, were really kind of our preference for the workforce that was going to do the vaccine in the private home. It's just it's a lot of responsibility there.
Okay. And I'll just tail on my second question. So we tried to reach out to the home health agencies. We got somewhat of a lackluster response to wanting to share names with us. Did you have any incentives or tricks or advice on engaging the HHAs?
Karen, there were several problems that we had. First, we had to get to fair market value to really incentivize them, and they make a decent amount of money per hour. So that was one of the ones that we had to really empower. We also had some lackluster but varied responses among our home health that we contacted. Some of them were actually pretty enthusiastic, and other ones were like, sounds like a legal problem and I don't have enough lawyers on my team. So
yeah,
it was, we kind of saw, we kept calling, and then we found about 5 or 6 that have really been pretty enthusiastic. So even though we aren't doing this for the entire state, we still vaccinate about 300 patients a day, primarily Bloom patients and patients who live by us, or their caregivers or loved ones. So we're using a lot of these strategies on a much smaller scale. But yeah, that's a hard workforce. And that's why we wanted to be really thoughtful and being able to kind of have the subcontractors at the home health, but also be able to employ them directly by Bloom if we needed to be. We figured different counties would look different.
All right, thank you.
I had another observation, and this is kind of Karen in response to you. And Karen, it's good to see your name, good to hear your voice. So I wonder, and I guess, Tom, this is a question for you as well, is has there been a connection with the AAAs in your area, and or other aging services groups that may have those names? Meals on Wheels, we've heard that some of the some of these different agencies and different programs that go into homes and deliver either services or food or other other necessities might have some of those names and lists.
Absolutely, Megan. And we haven't finalized the funding of this, but we've already started all of that sourcing work at the county level and state level. So we gave the state kind of a list of what we thought was going to be the most comprehensive way to find individuals in their home. And one of the problems with it, all states have a very, very narrow view of who's homebound. They're all kept Medicaid. If they don't get Medicaid, the state doesn't know about them, so they don't think that the Medicare patients are homebound, or that commercial patients are homebound, or that uninsured or undocumented patients are homebound. So we wanted to be very thorough with the state from a patient identification standpoint of saying, like, your list is not complete. It's far not, and we can't scope it around this list of Medicaid patients only. So we wanted to be able to be thoughtful on that. And so Medicare, pretty easy. They're getting home health, they're getting home services, they're maybe on hospice, area agency on agents. They know all kinds of other folks who may be homebound, including some of the commercial folks. And then we felt using Meals on Wheels and even using some public service announcements and probably multilingual public service announcements to really be able to get out there to folks who might not be connected with a system or with the language. And at that point, you're going to be pretty thorough. You probably will still have some gaps, but I feel like that's a pretty thorough way to kind of throw the net and to get all homebound patients. And it's, our estimates are going to be far off. By the time we get to the end, we'll kind of have a much more refined number. But we know that there's populations inside of each one of those groupings.
Yeah, great, thank you.
Thank you. I thought I saw another hand, but then it disappeared. So if someone was trying to raise their hand, I'm sorry, I didn't see who it was. But feel free to jump on. And if not, I'll just ask my last question. I'm curious, this experience in some ways it fits right into your wheelhouse and the infrastructure that you already had set up to begin with. But I'm wondering if nonetheless, if how this experience might influence what your services look like going into the future. Are there new practices, new efforts that you think might become part of your bread and butter that weren't there before?
I absolutely think we're going to continue this. We're continuing this effort all through the summer. So even though we're pretty much vaccinated all of the Bloom type of patients, we're vaccinating 40-year-olds and 30-year-olds, anybody we can get to in our parking lot. We're still doing a lot of folks in their private homes. We think this is probably going to give us really good practice for the flu season or for any other boosters or kind of second, vaccinations that need to come around if the virus has, mutated, et cetera. So we kind of feel that this is going to be an ongoing part. We've actually hired a great group of medical assistants, and a couple of them are like EMT/medical assistants. And we can use them in other ways in our practice to collect mobile phlebotomy and blood draws and help us with some of our urgent care televisit needs. So this has actually given us some other capabilities that we didn't ever anticipate. So yeah, it's been a good experience for us outside of just the kind of thanks and knowing that we're doing good work for the community.
Sure, marvelous. Well, seeing no other questions, and we are approaching the end of our time together, let's go to the last slide, please. And I'll just wrap up by saying that, oops, I'm not even on my last slide, sorry. That we want to thank you for this wonderful story of success and the dialogue. We will be sharing the slides and the recording following this event. TIFA is continuing to host these 30-minute huddle calls on Wednesdays and Fridays on topics related to enhancing access to the COVID-19 vaccine for people who need them administered at home. And our next call is on Friday, the 9th of April at 12:30 Eastern Time. And we hope you will join us and spread the word to colleagues as well. I am pasting the link to the registration in the chat, as I usually do at the end of these. And I want to thank you, Tom Lally, so much for joining us today, sharing your story and your wisdom on this topic. And thank you to everyone else here for all that you are doing as well.
Thanks.
Thanks, everyone. Thanks, Tom. Thanks, Margie.